As you've heard from Steve, there is mitral valve repair, and for degenerative disease, mitral valve repair is absolutely outstanding because it restores life expectancy. Steve, I'm so glad you confirmed our data from 1995 and following.
It took us a while.
So we have an extraordinary treatment. How do we treat MR at the national level? When we look at the burden of mitral valve disease, you have here the what we calculated in 2000 and published in 2006, that MR is the most frequent in the population and in the community. And when you calculate the increase of the population and the various segments of the population, that's the Census Bureau, and you look at the prevalence of mitral regurgitation, what you will see is that the number of patients affected in the US by MR will reach in 2030 almost 7 million, with 4 million that are diagnosed in the community and warrant treatment. Compared to that, to this kind of numbers, what we have in surgery is approximately 30 to 40,000 operated yearly patients. So clearly, at the national level, we're not operating the patients that are there in the community. And it's not a matter of saying, oh, I'm the surgeon, I'm doing the best. The problem is that a lot of patients are escaping, and we're going to see that. So is under-treatment because it is underdiagnosed? No doubt. In the Oxvalve study in England, they showed that a number of people who had a systematic echoes were detected to have a valve disease. And again, the most frequent valve disease was mitral regurgitation. That's significant. That is less than significant. The green is less than significant. The red is significant. So clearly there are people who need to be diagnosed because there is not always a murmur with MR, and we need to catch these patients. And in the referral centers in Europe, 50% of patients with severe MR symptomatic are operated only. In the US, it's the same thing. University of Michigan, 50% of the people who have mitral regurgitation, it's a small number, but still 50% are operated. So whether you're in Europe or you're in the US, 50%. So that gives an idea about undertreatment in the referral center, but that doesn't give an idea of what's happening in the community and how many people we treat. If we look at the community, in a sense, Olmsted County is a privileged community because you're within walking distance from Mayo, where everything can be done, every test, every surgery, every coronary, every intervention. So you don't need to have a car. You can take your bike, even in the winter, and you get there and you get operated. And we have all the cases that appear in the community, and we can say, okay, of all these cases, how many get treated in their lifetime? And so that's the paper that we published in Lancet last year, and it's interesting. So that's the only comment that I will to respond to your question. We submitted this paper to New England Journal of Medicine first, and the reviewer said, oh, that happens to these people in their small community, but that doesn't happen in Massachusetts. So that was an interesting comment about undertreatment. It doesn't happen in Massachusetts. So fortunately, Lancet took the paper, and what we see is that MR in the community is diagnosed in the early 70s, so it's older than what we thought. There is a high mortality associated with MR overall. And when we look at high EF, low EF, you see that overall, only 15% of patients are ever operated. Of people who live in Olmsted County within walking distance of the Mayo Clinic, only 15% are ever, during their lifetime, operated. It's a little better when the EF is above 50%, but it's very low. But still, we're dividing the patients by just the EF above 50, below 50. That's not completely satisfying. And so this week was published a paper on the causes and mechanism in the cases of the echoes that we're able to review because they were electronically stored. So we have a complete description of what is MR and how they are followed. And what we saw is that 2/3 of the patient had functional MR. And you see the various causes are indicated by the color. And it's very heterogeneous, including the organic MR. And so you see at the end, we keep 3 groups mostly. FMR due to ventricular remodeling, FMR due to atrial remodeling, and organic MR dominated by degenerative mitral valve disease. So here is an example. 72% of the organic MR is degenerative in the community, and it can be any form of MR. And then there is the classic form, the coapt form, the FMR due to ventricular remodeling, sometimes with an EF above 50%, but rarely, mostly with reduced EF. And that's the type of functional MR that we know. And then there is this type of MR, the FMR, the functional MR. You see the valve is moving completely normally, and it's due to atrial remodeling. Isolated atrial remodeling, the ventricular function is excellent. All that group, this group, has not been addressed in any clinical trial. You see the enlargement of the annulus, you see the MR, you see that the mitral is normal, and we can quantify that MR. You see there are 2 jets at 2 areas of the commissure, 2 areas. We can quantify, and very often there will be a significant CR associated due to annular dilatation of the tricuspid valve. The age distribution is different. In red, this is the FMR atrial form, with affecting mostly the older patients, and the distribution of organic and FMR due to ventricular remodeling is distributed throughout the ages. What happens to this patient is summarized here. If you retain this, we're good. So 2/3 of patients having functional MR, 1/3 having organic MR. The differences are striking. The people with the FMR in the atrial form are older, 80 years old, mostly female, very frequently with atrial fibrillation, with a normal EF, with a normal left ventricular size, and with a regurgitant volume of 37 cc's. What is interesting is despite this low regurgitant volume in that form, you have an excess mortality and a high rate of heart failure. And these patients are almost never operated during their lifetime. They die with their MR, and we don't know if the degree of MR is a predictor of outcome. We don't know if treating the MR is going to make them better, but this is a very large group which requires attention and is mostly due to a type 1 annular enlargement. This group here we know very well. It's the people within the coapt, and it confirms that the standard of treatment is not surgical. But what is interesting is the organic MR. Only 37% of them are ever operated. So even if you have the good surgeon, these patients and the people who manage them, they are not referred for treatment. So we need clearly to improve the referral of these patients to be treated. There is a treatment. There is repair that can be done in the vast majority of these patients. How come they are under-referred, under-treated? And we have to really make an improvement here. So in summary, when we look at the mitral regurgitation, the under-treatment of MR is enormous, and the burden of MR is enormous, highly impactful for outcome in all the subsets, seriously underdiagnosed and seriously undertreated. And we need to develop strategies helping valve centers to reduce the MR undertreatment and address the MR health crisis. Thank you so much for your attention.